Thank you so much, and thank you for inviting me down. I arrived yesterday afternoon, and I've given a couple of talks and spent some time with the Ethics Center, and I'm very impressed with the careful and thoughtful approach being taken to implementation of aid in dying. So Oregon's Death with Dignity Act was passed by popular by ballot measure in 1994, and after legal challenges, implemented in 1997. And during that time, I and my colleagues have performed a series of studies and surveys in patients and family members and healthcare providers to understand about their views and experiences around the law. So one of the studies we first did was a survey of 4,000 eligible physicians who would be eligible to prescribe. In 2000, we did everybody because we just didn't have a clue what was going on. There was no real way to do a power calculation. And at that point, 5% of physicians had received a request for a lethal prescription. One of the arguments around physician-assisted death was that we should consider hospice as an alternative. But in fact, the majority of patients we were finding were enrolled in hospice at the time they made a request or received a lethal prescription, 91%. And so we did a survey of hospice nurses and social workers in 2001. And at that point, almost a third had cared for a client who had made a lethal prescription. We also did a study then in 2005, 2006 of patients who explicitly had requested physician aid in dying to understand their reasons for making the request. Why do we care why patients make these requests? The reasoning. And it's because even if one supports the law, we hope and aspire to this being an option of last resort. And so we're looking for other potentially treatable or addressable conditions so that the patient would potentially make an alternate choice. So what do we know about Oregon's experience? Well, there have been almost 1,000 deaths by physician-assisted death between 1998 and 2015. We had worried when we were debating the law that people would make this choice because they were disenfranchised, vulnerable, unable to access care. And what we found was just the opposite. 97% of deaths in Oregon from physician-assisted death have been in people who are white. They're equally divided between men and women. 91% are hospice enrolled. Sunita will talk more about hospice, but it is really the Cadillac of comprehensive end-of-life care. Most die at home. And in a state where 15% of people have lacked health insurance, only 1 to 2% of people who die of aid in dying lack health insurance. I don't know of a situation or condition in medicine that we've worried so much about for which the risk factors have been being wealthy, white, and insured. In addition, people who make this choice are 8 times more likely to have a bachelor's degree. In all of our studies, we have a simple 0 to 10 scale that asks people the importance of religion in their life. Not surprising, religious belief is protective against making this choice. But I think what's more interesting is that no matter which group we ask, in terms of healthcare providers, they have a mean score of between 6 and 7. But people who choose physician-assisted death have a mean score on this scale of 2. They are the singularly most unreligious group of people that I've ever interacted with. It's simply not important in their life. I mentioned yesterday we also used to have a 0 to 10 spirituality score, but in fact, everybody in Oregon scores on an average of 9 on this. And so, showing no variation, we ultimately deleted that measure. In the discussion of legalization, one of the major arguments was around the role of symptom management. The concern that patients would make this choice because they had untreated pain or untreated symptoms, and the argument that we are getting better at treating pain and that should be our focus, versus the argument of the other side who said not all pain could be treated. So in our study of requesting patients, we had them mark about 20 different reasons why they may make this choice, with 1 not important and 5 as important. And in terms of their current symptomatology at the time they made a request, the mean score in all of these was 1. These are surprisingly unsymptomatic patients. Now, one of the things is that there's probably only about 30 to 40% of people who we had requested participation participated. So sicker, more symptomatic people maybe didn't participate. But in fact, in our study of hospice nurses, they consistently said that people who made this request had fewer symptoms before their death than most other hospice patients. But interestingly, if you look about patients' worries about the future, this is a key issue. It's not the symptoms they have, it's the symptoms they're worried about in the future that are motivating them to make this request. As a psychiatrist, I particularly worried about the role of depressive disorders. We know that depression is the largest risk factor for suicide in the country, that depression is treatable, and when treated, people will be no longer suicidal. Interestingly, among our requesting patients study, about a quarter of the patients had a major depressive disorder, which is about the rate of major depression in terminally ill patients. So there's not a clear, is it attributable risk? Did I say that? Social workers, clinical social workers who have a great deal of experience with mental disorders in patients at the end of life, rated on this 1 to 5 scale depression as among the least important reasons patients were making these requests. So that was reassuring, though among the 15 in the patient study, 3 of those patients did access lethal prescriptions very soon after participating and died very quickly without ever receiving a mental health evaluation. So this is one of the areas of the law that is not working as well as we had hoped. So if it's not depression and it's not pain and it's not the care that they are giving, why do people make these requests? This is really about people's wanting to be self-sufficient, in control, and independent. And in fact, if you look at the future state, I have to stay here, the future state of control, the median score on the 1 to 5 scale was a 5, and the interquartile range was 4 to 5. It is almost unheard of to have a patient make this request and not have the major reason being about their control. In addition to our surveys and many of these studies, we did qualitative interviews with physicians. We did interview 35 physicians across the state. And I think this is where we get a better idea about the role of control. One physician said about a patient, but these were individuals who wanted to control their lives, and it was mostly a control issue. And they sort of stated it at the get-go. It had nothing to do with the care they were getting. And they would return to it, and you could say, well, you know, we're doing all we can. We're making this commitment to you, and we're trying to take care of you. But they sort of fixated on ending their life from the get-go. Another physician about a different patient. He was a very stable patient. He wasn't someone who was in a lot of pain physically, and he was the captain of his own boat. And that's how he had been his entire life, and he wanted to die a certain way, and he did it, and I think he just ultimately wanted to have control. A story, again, from a different physician. When I saw her, she was very, very weak and very dehydrated. And again, I told her, gee, you're within a couple of days of losing consciousness just from dehydration. And we could make sure you slept and did not suffer, and it would be a short time. She had made a decision, had the 14-day wait, and had 4 more days before the medicine could be prescribed. And I told her I didn't think she'd be able to do that unless she could solve the nausea and the dehydration, that she would last 4 days consciously to take the medication. And she struggled into a sitting position and asked her husband to get a glass of water, and she says, I'll get the fluids down somehow. See, that's the paradox, where you learn that lesson about the control issue, that she actually reversed the natural process to prolong her suffering, if you will, in order to be to control and to push the button herself. In addition, these are very highly independent and focused on self-sufficiency. Just an example, he was a typical rural resident in the sense he was tough, macho, in control of himself and everything else kind of fellow. So in summary, many of the findings have been counterintuitive and unexpected. That this is really not about care people are getting. If in fact, I would say there's an unusual disparity so that people without resources may want this option but appear not to be accessing it. And the other factors that are associated are this low measures of religiousness, strong need for control, prizing self-sufficiency, not wanting to be dependent on others, struggling to find meaning in the dying process, fear of worsening symptoms, and lack of denial about the future. Thank you.